Good afternoon. I'm Joe Bilson, the Chief Executive Officer here at Wills Eye Hospital. I'd like to thank everyone for being here today. We appreciate you coming out on this beautiful day to join us here at Wills Eye Hospital for the Ophthalmology Allstars. This is the third event of a series of events that we'll be having here at the hospital. We'd like to welcome our 1832 Society members and also welcome those who are coming to Wills for the very, very first time. We appreciate you coming today to our great institution to share this afternoon with us. I wanted to also mention to you my partner, Dr. Julia Haller, would normally be here and co-hosting this event for us today. Unfortunately, for us, but great for the nation, she's in Florida being an expert witness in a very, very important case for the United States Attorney General that affects ophthalmology and the way we practice today. And her work is so important there today. She sends her apologies for not being with us today, but we wish her good luck there and doing great work for our country and ophthalmology in general. So she sends her very best to each and every one of you. Lastly, I'd like to talk and take a moment to talk about a very, very important person in our history here at Wills Eye Hospital. I was greatly saddened last night to find out that my friend, our leader here at Wills, Bill Tasman, passed away. He was a giant, a cornerstone in ophthalmology, a cornerstone in Wills Eye Hospital's history. I had the great pleasure of sharing a party wall in an office back in the day, 30-some years ago, in the old Wills Eye Hospital. I got a chance to see him on a regular basis, and there was not a greater person, not a greater doctor that I ever met in my life. And he's going to be greatly missed. And for a moment, for the Wills family and the people who knew him, his family, I'd like to take maybe 10 seconds, a moment of silence, so that we can remember him and his family in this very, very, very difficult time. The medical staff, we grieve here because we are a family, and he's going to be greatly missed here and in ophthalmology in general. And he's contributed his life to taking care of patients the best that anybody I know could. And so what a contributor, what a leader. So I'd like to take 10 seconds for him. Thank you. We have a really very special program for you today from two really well-known, world-renowned surgeons here at Wills Eye Hospital, Dr. Robert Bailey and Dr. Carl Regillo. Rob and I have been friends. We were just talking about this a little earlier. I came in 1834. I'm sorry, 1834. I wish that was the case. 1984, I came, and Rob was coming out of residency and becoming a major leader here at Wills and the head of our Cataract Service, and Carl Regillo, chief of our Retina Service and a great leader. And so those two individuals will be talking to you today about cataracts, retina, and macular degeneration a little later. But for now, what I'd like to do is offer you a great lunch and enjoy lunch, and then we'll come back and start the program. And if I can make it to 1834, I'll be ahead of the program. Thank you. I hope you're enjoying your lunch. I have the great pleasure of introducing Dr. Robert Bailey, Chief of our Cataract and Primary Eye Care Service. Rob, as I mentioned earlier, has been here for a really long time, just like I have. He's had the opportunity to train and be a part of the careers of over 300 of our residents over these years. A tremendous leader, a great friend, and a real expert in cataract surgery, advanced cataract surgery, and complications of cataract surgery. So, Rob, you have the floor.
Thanks, Joe. It's a real pleasure to be here. And I don't quite go back to 1834, but you know, I may be getting there. But anyway, what we're going to talk about today is cataract surgery and some of the things that are developed that Wills has been part of, and also where things are today, and then looking towards the future where we may be headed. First, let's start out with some elementary things, and I apologize to the ophthalmologists in the crowd, but let's start out with Cataract 101. What is a cataract? And many people feel when they come in that it's just a film over the eye, and actually it's a clouding of the lens of the eye, and the lens basically is an object that focuses light. It's behind your pupil. Light comes in through the front of the eye, through the cornea, through the pupil, then through the lens, and is focused on the retina by the lens. And a cataract basically is a change in the protein structure of the lens that then causes the lens to opacify or become clouded. Well, what's a cataract look like? What does a lens look like? And basically, what I tell people is it looks like a plain M&M. The lens of the eye is basically shaped like an M&M, and it's kind of like that in terms of having an outer covering, or it's a capsule. It's not as thick as the candy on an M&M, but it's a nice outer covering, and then there's some substance inside. There are a lot of myths about cataract that go around, and you know, patients come in and you talk about them and try and dispel some of these things. But first, again, a cataract it's not a growth. It's not on top of the eye. It's not a film over the eye. You often go to the pharmacy, and you may see things online or in the pharmacy about drops that may help cataracts to dissolve. And unfortunately, that where we are today, we don't have anything that will dissolve a cataract. A cataract is something that everyone's going to get over time, and at this point in time, it becomes a surgical disease once it gets to the point where it's interfering with people's activities. Things that you do with your eyes do not make cataracts worse. You know, doing reading or sewing is not going to make a cataract grow. Again, everybody's going to develop it. It's going to grow over time. Cataracts, unfortunately, aren't reversible. There may be times when people feel like their vision is better one day than another, and that may depend on the type of cataract they have and the part of the lens that's cloudy. But they will not go away. Well, cataract surgery is dangerous, and recovery takes months. Well, you know, fortunately, this is a very successful, safe operation, and people's recovery nowadays is remarkable. I have people leaving the operating room, and they're already saying they're seeing better, or they're complaining that they're not seeing as well as they'd like to be leaving the operating room. Cataracts grow back. You can get a cataract. People wonder whether their cataract can come back after you've had it removed, and that will not happen. It's a one-time operation. One thing that can happen, we leave behind part of the lens of the eye, which is removed at surgery, called the capsule, that outer candy, to hold the new lens that we put in, and that sometimes gets cloudy, and that's what's called a secondary cataract, and that's what people sometimes refer to when a cataract is growing back. Well, people wonder whether taking vitamins or nutrients may help to prevent cataracts, and there's some studies that have shown that vitamins may slow the rate of cataract surgery, of cataract growth, but there have been other ones that showed no change in this. So the word's not out on whether nutritional supplements may make a change in the growth of cataracts. Taking aspirin can prevent cataracts, again, something that some people feel. That has not been shown to be effective. question is can we just use laser to remove cataracts? Well, this is up until recently. This was definitely that lasers were not used for the primary surgery. They were often used after the surgery, as I said, for people that get a secondary cataract. Nowadays, there are lasers that are used for parts of the surgery that can do it very precisely, but it still does not take the need to go into the eye and remove the lens particles at surgery. Another myth that cataracts only affect older people. Well, we're seeing more and more younger people with cataracts, and that may be for a variety of different reasons. Part of it, I think, is that we've gotten so good at removing cataracts and the results are so good that people just aren't waiting as long to have their cataracts removed as they used to. But there's some risk factors that may lead to cataract development at a younger age. Certain diseases such as diabetes, heredity certainly plays a factor, injuries, smoking, excessive drinking, or overexposure to ultraviolet light may play a role. Well, cataracts are common. In the United States, probably over 24.5 million people in the United States have cataracts. And in the United States, the number's been increasing, but about 4 million cataract surgeries are performed in our country per year, and 20 million performed worldwide. And again, more people having cataract surgery each year and at a younger age. It's a safe, successful operation, and there's certainly incredible impacts that it has for people following cataract surgery. The mortality rate has been found to be lower in patients following cataract surgery than those who still have a cataract. There's a study that showed that the odds of getting a hip fracture are reduced significantly, 16%, compared to those with cataracts. And car accidents have been found to be less frequent in patients that have had cataract surgery, and just resulting from better vision, able to be more independent. There's always studies recently in medicine. We're looking at things that are in terms of looking at ways that different procedures and treatments improve people's quality of life. And cataract surgery is a huge benefit to patients in terms of their quality of life. In patients that had one eye done, there's been a study found that 21% gain in the quality of life after cataract surgery, and even more improvement after they have both eyes done. And the cost benefit to society is huge. If you look at things over a 13-year period, they estimate that a $123 billion cost benefit to society, because you're basically restoring independence to patients, making it able for them to return to work, driving, reading, other things that they are able to do. Vision correction after surgery, there are really three things that I want to talk about that really changed a while ago that kind of revolutionized the treatment of surgery, of cataracts. First is the vision correction after surgery. Years ago, patients had to have thick cataract glasses or contact lenses, and they were the only options until the early 1970s. The cataract glasses that people wore would create a lot of distortion, a lot of problems with their peripheral vision, and often the feeling was that life without a cataract wasn't a whole lot better than life with a cataract, and because of that, people often waited very long time before they would have surgery. There's a Dr. Ridley, Harold Ridley, who was a British doctor, and he was the first person to successfully implant an intraocular lens, and that was done in 1949. And the idea came to him actually after a question from a medical student. He was performing a cataract, and the medical student came to him and asked him, well, you're taking the lens out, why don't you put something back in? And that and some observations that he saw with pilots from World War II who'd had sustained injuries and had intraocular pieces of the windshield or perspex in their eye, and the eye was tolerating this material very well, led him to believe that maybe we could get a lens that could replace the lens that you're removing in cataract surgery. And this was the design of his first intraocular lens, the Ridley lens, and this was placed in the eye after cataract surgery. And these lenses, even though there was a significant incidence of the lens not staying where it should be, creating some inflammation, some of these were extremely well tolerated and just even a few years ago have patients that still have these lenses and are doing well. Warren Reese, who was a Wills resident and completed his residency in 1918, was actually, he implanted the first Ridley lens in the United States in 1952, so the first, a Wills connection to this, to the intraocular lenses, and again, this was a huge step forward. Well, this, again, just a patient showing a patient with aphakic glasses and what some of the distortion that they had, and this reminds me, I just saw a patient in the office yesterday who was a young 20, came to me about a year ago, a 21-year-old. He'd had cataracts removed as a child, and at that time, you know, we were implanting intraocular lenses in older people, but there were, you know, putting them in a child was felt to be not safe because of the many years that they had to live. So he was going around, he could not wear contact lenses, and he was going around with cataract glasses until he was 21, and he was just kind of counting the days down to he was 21, and maybe you could have an implant. And he was bound and determined to have this done. I saw him. We did one eye, and he did very well. About 4 months ago, I did the second eye. And he came back yesterday, actually, for his one month visit after, or 2 month visit after his second eye. He had the biggest smile on his face you just would not believe. I mean, he now was able to function without glasses. His self-esteem, his confidence was so much better. He's able to drive, and just, you know, this is what happened when with all of our patients when intraocular lens became available. It's still happening with some younger individuals who, again, had to have cataract surgery without intraocular lenses. One of the other things the next thing that was a big important was the advance of microsurgery. Cataracts initially were removed with, you know, when we had, before the advent of microscopes, you did it without any magnification or just with loupes, which provided a small amount of magnification. But because of that, our ability to close the wound that was removed at cataract surgery was not very good. Because of that, patients had to be pretty immobile after surgery, although you'd create problems with the wounds leaking, and you'd hear stories about where, you know, being in the hospital for 2 weeks and sandbags and not being able to move and whatnot. And that really improved once microscopes were available. And Zeiss introduced the first surgical microscope in 1953, and Wills had its first operating microscope in 1967 and 1968. And this allowed much better visualization and wound closure. The next thing that had a Wills connection was Charlie Kelman. And Dr. Kelman was a Wills resident from 1958 to 1960, and his actually first passion was music. And he loved music. He was a saxophone and a clarinet player, and his father, you know, was trying to convince him to go into medicine, and basically sent him down to the basement one evening and said, "I want you to play this Tommy Dorsey song." And he played the song as best he could on the saxophone. And his dad asked him afterwards, "Do you think that you played that as well as Dorsey?" And Charlie said, "No." He said, "You're going to be a doctor's son." So anyway, so Charlie did some great things here as a resident. Once you could get him back in from not playing with playing jazz in various parts of Philadelphia. But in '67, after he graduated, he'd had a grant for trying to develop a way to take cataracts out through a small incision, and he had lots of different ideas of how to do this, and none of it was working. And finally, he went to the dentist one day, and they were cleaning his teeth, and he heard some sound, and he asked the technician what they were doing, and they using ultrasound to remove the plaque from his teeth, and he had a eureka moment, and he decided that that's what he'd try to take cataracts out, and that's what he found to be successful. And basically, the lens nowadays, and it's still the primary way that the cataracts are being removed today. The lens is emulsified with ultrasonic energy. The pieces that are created are then aspirated from the eye. And the advantage of this, like a lot of surgery, it allows us to take the cataract out through a small incision and that has led to more rapid recovery and a quicker return for patients to their normal activities. So another Wills connection, now, we're all certainly very familiar with YouTube nowadays, and you can see anything. But Ray Adams was the chief of the Cataract Service shortly after I finished my residency, and he, in May of 1991, did a live cataract surgery on WHYY, and that was just an incredible event, and just a brave man to do that. But I just wanted to show you just a brief.
Her surgery, which will begin live in just a moment. But first, let's meet tonight's surgeon, Dr. Raymond E. Adams, ophthalmologist for over 25 years and the director of the Cataract and Primary Eye Care Service at Wills Eye Hospital.
Welcome to the operating room. I'm Dr. Ray Adams. Before we begin tonight's microsurgery, let me introduce you to our staff. Assisting is Dr. Daniel Kane, co-director of the Cataract and Primary Eye Care Service.
Well, that was it was a kind of a revolution, a breakthrough thing that really people got to see exactly what was done. And, it's not everybody wanted to watch it, but it was the piece was incredibly well done. It was a real boom for Wills and for cataract surgery, certainly. Well, let me tell you a little bit now about the cataract service at Wills and what we do. Well, CPEC, which is Cataract and Primary Eye Care Service, which Dr. Adams actually coined the name, is one of the largest departments at Wills, and there's over 25,000 patient visits per year. The patients are seen there for routine eye problems, and certainly if they have complicated or subspecialty problems, they are referred to the Wills subspecialty services such as cornea, retina, glaucoma, and other places. The Wills residents there work with the attending physicians to see patients, and the attending physicians are people that have a lot of experience in general ophthalmology, comprehensive ophthalmology, and have an interest in teaching. So they come in, they spend time in the clinic. I have 40 attending physicians that come and spend usually half a day a month with the residents, and really gives the residents incredible breadth of experience and a lot of different ideas on how to take care of different problems. Resident cataract surgery training is really a big part of what we do, and we have several courses that we have. We have developed a mentor program which pairs an attending surgeon with a resident to spend some extra time with them individually for one-on-one training. Wills has an incredible wet lab for microscopes and cataract machines and instrumentation for them to practice and work with their mentors and other residents. We have a simulator. There's a lot of practice surgery nowadays for different specialties being done with virtual reality simulators, and Wills was one of the first residency programs in the country to have such a simulator, and it just has, we saw shortly after we had access to the simulator, a real improvement in the patient's comfort and their surgical skills by the time they got to the operating room. It was really a boon for us. And we have 15 to 20 surgeons who come in and spend time working with the residents with their cases, and it is it's a nice place because the depth of talented people, all with slightly different approaches to how they handle things, really gives the residents an incredible experience. And this is, certainly one of the real enjoyable things about being at Wills is teaching, and you get the number of people. Wills has trained more ophthalmology residents than any ophthalmologist than any program in the country, and for years I was on the residency selection committee, and just seeing the talent of these candidates came in with was unbelievable. I was fortunate there were 13 residents when I was here, so I was able to sneak in. If I was coming this year, there's absolutely no way I'd be selected. But the talent and of these candidates is unbelievable. I had one of the residents that trained here several years ago, his parents were missionaries, and he grew up in Africa. His name is John Cropsey, and then he came to the States for college and medical school, but he was homeschooled and spent his first 17 years or so in Africa, being homeschooled by his mother. Met a couple like-minded individuals in medical school, and they had a plan that when they were going to finish, they were going to go back to Africa and build a hospital. This is when they were first-year medical students. So you think, well, everybody's got pie-in-the-sky ideas. There's no way that would work. Well, they all stayed committed, went through their medical school. He came to Wills for his residency. A couple of his friends did another was in orthopedics. Another person was in cardiology, I believe. They all still kept this goal. They had families. All the families were on board, and they've gone back. They went back. They're in Burundi in Africa, and they are have built a hospital. They're starting a residency program. It's unbelievable. But when he was a resident, I can remember I did a case with him one time. I was staffing the emergency room, and a patient come in with an injury, and Peter Lapson is in the audience would be familiar with this. A patient that had radial keratotomy, which was a way of correcting nearsightedness, and basically in that a lot of very deep incisions were made in the cornea, and those incisions would never heal. And if you got hit hard enough, it's always the eye's going to give at its weakest place, and these were the incisions. This patient's eye gave in a lot of places where these incisions have been made. And this young resident, the third year resident at the time, starting in his beginning of third year, not a ton of surgical experience, put this eye back together like you thought he'd been doing it for the rest of his life. Nothing fazed him. And he's continued to do that, and he's an unbelievable individual. But it's so much fun to work with these talented physicians and residents. It's just part of what really makes my day. So this is the surgical simulator. Just wanted to show you what that's all about. The residents can work with this. It teaches them some of the bimanual skills where you're using both hands. It has a visualization that looks like you're doing surgery in the eye, so you can see what you're doing and what you're accomplishing. And again, it really has helped to give them a good couple steps forward in terms of once they get in the operating room doing surgery. Well, Wills Cataract Surgery, there's over 30,000 cataracts performed every year in the Wills network between down here at Wills Eye Hospital and the surgical center network. The hospital and surgery centers have made the latest technology and surgical equipment available to us. The experienced personnel from registration to preoperative, operative, and postoperative care are unbelievable and really help to make the patient experience as good as it can be, and it really is a tremendous one. The nice thing, being down here, we have the access to Wills subspecialists, doing the most complex cases. It makes it really, really something that we're able to perform. I often work with someone with Dr. Regillo or someone in his department, some of the glaucoma departments for some of the more complicated procedures that we do, and having the availability of that and being able to provide that to the patients, as well as the more routine cases. And I mean, no case is routine, but with the more routine cases, do a tremendous job. Well, what's new? You hear a few things, and you may wonder what's down the road and what is happening. Well, one of the big things that is being talked about is what's called laser-assisted cataract surgery. There's something called a femtosecond laser, and it is being used for parts of cataract surgery, and it is able to very precisely and elegantly do some things that we do now or in a routine case by hand. And it's true, it's able to make some incisions and do parts of the procedure that may be able to make the surgery safer. It's not clear whether this is truly going to get better outcomes. At this time, all the studies have basically shown it seems to be as good as what we have been doing. It's not been shown to be any better. So there's some skepticism, and some people are kind of on both sides of the fence in terms of where this is. But it's something that you may hear, but it doesn't replace the need for going into the eye and taking the cataract, the actual cataract out. So it's used for parts of the surgery. There are new lenses that are constantly being made available, and the idea of the lenses is basically to make people more independent from their, in terms of their need for glasses. There are lenses now that can correct astigmatism. There are lenses that are able to give people distance and near vision, so that if people desire independence from the need for glasses, then they're more able to achieve that. You may hear people talking about dropless cataract surgery. One of the things that patients often complain about and call our offices about is the need for getting drops and the expense of drops and the difficulty putting in drops. And there are some companies now that have come up with injectable materials of some of the medications that we use after surgery that are put in the eye after surgery. And that drug delivery is something that is changing in glaucoma, in retina, and it may come to cataract surgery as well. So this is something that, again, not everybody is embracing. There's some risks associated with it and some problems, but it may be something that you'll hear about as well. Finally, can drops be used to dissolve cataracts? And this is something, and again, some of the over-the-counter things that you may see certainly are not going to have any role, but there's been a couple studies showing that some sterile drops have been shown to dissolve some of the proteins that can lead to cataracts in dogs. Now, whether that's going to translate into any use in humans is unclear at this point. This is just some of the advanced technology in intraocular lens. This is a multifocal lens with the rings that are often used, and this is a astigmatism correcting lens. Well, in summary, again, cataract surgery is one of the most frequently performed surgeries in the United States and one of the safest. And one of the greatest benefits of the surgery is the increased quality of life it gives to our patients. I just want to read you just a brief note that a patient gave me just to give you an idea of what I hear and which really helps to make my day every day. Dear Dr. Bailey and staff, just a note to say thank you and your staff who work in the office and in the surgical center, who are so caring, kind, and patient. Dr. Bailey, you've given me eyes that see colors which now are so vivid, see street signs which I could not see before, see the TV guide which I had to stand right on top of the television to read before, etc., etc., etc. Thank you from a most grateful patient. And this, I think really what we're able to do is improve people's quality of life, give them more independence. It's really a gratifying, wonderful gift that we have. But thank you again for your attention.
Our next speaker is Harold Regillo, the director of our Retina Service. Carl's been a great leader here for a really long time. He heads the Retina Service, teaching, education, research. He's going to talk to us a little bit about macular degeneration. Carl?
Thank you, Joe. Good afternoon, everyone. It's a pleasure to be here to talk to you about a retinal condition called macular degeneration, which I'm sure you've heard about at least to some degree. We've moved, we are moving from the front of the eye to the back of the eye. Dr. Bailey gave a nice presentation on what cataracts are, how they're dealt with. That's in the front compartment of the eye. The macula is the retina. It's the back part of the eye. Before I start, though, this talk, I'll be talking about all the exciting developments over the past decade in macular degeneration treatment, and a lot has happened. I think you'll enjoy hearing about what has been done and what will be done. But before starting, I want to mention our great mentor, Bill Tasman. Bill Tasman was the head of the Wills Eye Hospital for 25 plus years. He was here during my training. I did my ophthalmology residency and fellowship here at Wills in the late 80s, early 90s. I left Wills to fulfill a military obligation and practice retina in the Air Force out west in California. And it was Bill Tasman that gave me the opportunity to come back to Wills to the Retina Service to join his group and the Retina Service here at Wills after I finished up in the military, and that was about 20 years ago. And it was with his support and mentorship, friendship and guidance that we've helped to build a great retina service with me and my 22-plus colleagues. And you'll see that all the developments I'll be talking about today were part of, we've been a big part of in terms of the research program that I helped to start when I came back. So I owe a lot of that to Bill Tasman. So let's start with what the macula is. You'll hear this term a lot. You'll hear a patient say, I've got blood pressure, right? Well, we all have blood pressure. And I've got a macula. Well, we all have a macula. The macula is the center of the retina. It's what the image is focused on. So here is similar cross-sectional diagram of the eye as Rob showed. The image, the light rays which form the image are focused by the cornea and then the lens and cast upon the center of the retina, the macula. We can take a picture of the macula, or you look in when we do our examination after dilating the pupil, and this is what we see. This is the macula. This is the optic nerve, and these are the blood vessels of the retina. And then we now have technology, scanning technology, where we can take a cross-section of the macula and get scans that look just like the anatomy. So any condition, like macular degeneration or other types of macular problems, if they get severe enough, will cause some degree of visual blur distortion. It affects the center of your vision. And of course, if it gets severe, you're going to have severe central distortion vision loss. This can be legal blindness level. If you destroy the macula, you will not see the eye chart. You'll be worse than 2400, and that's legally blind. And if that happens in both eyes, like it can happen with macular degeneration, there's significant disability. So what is macular degeneration? As the name implies, this is a degenerative retinal disease involving just the macula. It is, still is, has always been and still is, the leading cause of severe vision loss in patients over the age of 50, not only in the United States, but in virtually all developed countries. There are two basic forms. I'm sure you've heard maybe dry versus wet. Well, that's the two forms. Dry is what most people have, and that's good news because most early dry stages are not all that harmful or affecting the vision all that badly. And then there's the wet form. The wet form is much more destructive and without treatment will almost always lead to severe vision loss. And that's why 90% of the significant vision loss with AMD, Age Related Macular Degeneration, is from the wet form. And that's been our biggest challenge through the years. There are a variety of risk factors. When you see a list of risk factors for getting AMD, that usually implies it's a multifactorial disease. Some of these things we can change and some we can't, of course. You can't change who your family is, how old you are, your gender, well, maybe your gender to some degree, but you're not going to change your risk of AMD. But there are some lifestyle changes that can be made to possibly benefit a patient that is at risk for getting AMD. I've got AMD in the family, and so I think a healthy lifestyle is likely to benefit me and everyone else in my family. Smoking is a major independent risk factor that, of course, you can change. It makes everything look old, as you can see here. Don't smoke. Don't be like her, like that commercial. There are potentially other things lifestyle-wise that might benefit it, but smoking is a key modifiable risk factor. Otherwise, we can't really change anything else. So what is AMD in terms of the course? Because what's going to happen is you may be 55, 60, 65, you're getting an examination, and the doctor's going to say you have some signs of AMD, and most people start to get very anxious because they've heard of people going blind with this condition. But the good news, again, is in this early stage where the ophthalmologist that's looking in will see these yellow deposits called drusen, and that's what these are. Those are the early findings of dry AMD. At this stage, actually vision is not affected. Patients are seeing well and usually doing well. But over time, that could be 5, 10, 15 years, one of two things can happen. There is some degree of progression. It can suddenly turn into wet, and that's a rather sudden event. Usually people recognize new distortion and central visual blur, and without treatment, that usually leads to severe vision loss within about a year. So that has to get detected because we now have good treatments. A much slower progressive process is continuing on the dry spectrum to an advanced dry form, and that can also affect vision quite a bit. And the good news there is it's not all that common for people to reach this end-stage dry form of the condition, but nonetheless it does happen because we're all living longer. So if you're diagnosed at 65, when you're 85 or even 90, you may actually have an advanced dry form. So you may have heard about vitamins for the eyes, and there is some truth to this. Yes, we do recommend vitamins for the eyes, but not any old vitamins. There have been 2 landmark National Institute of Health studies called the AREDS trial, Age Related Eye Disease Studies. We're one of the testing centers. We're proud partners in investigating sites for both AREDS 1 and 2. And what that showed was a relatively small but significant reduction in the risk of progression to AMD when people were randomized to take the full so-called AREDS vitamin formula, which is a mix of some antioxidant vitamins and minerals, including zinc. It's not a huge reduction, but when you look at the public health impact, you're going to reduce your risk from 28 to 20%. That's what this graph shows over 5 years. But it's relatively inexpensive. It's readily available. And if everyone with AMD at risk took the AREDS vitamin, you could see a significant decrease in the event rates of advanced AMD in our population. So yes, there's a plethora of products out there legitimately because of these studies. And so any product for a patient that has AMD, if they're taking a product that says AREDS or AREDS 2, then they're deriving some benefit, and that's good news. But dry AMD, unfortunately, has no other real treatments. So if you're going along that spectrum of progression of dry and it's starting to affect your vision, unfortunately, we have no way to alter that course. So patients in this dry form, we are unable to really prevent that progression that will occur slowly over time. We're looking for ways to slow it, prevent it, or reverse it. We also actually don't have a way to prevent going from dry to wet. If we could do that, that would really have a huge impact on this condition. So what's the future of the dry-sided generation? Because all we have is vitamins for that. We are looking into, and we've tested a number of drugs. We've had a number fail, unfortunately, but there's a promising one in phase 3 studies right now. Again, we're part of that protocol. We've been involved in testing drugs through all phases, 1, 2, and 3 of the FDA to see and test safety and effectiveness. And the one that's looking particularly promising has just finished up in trials and will have results in about a year. So it could very well be that within about a year and a half, we may actually have our first true dry AMD treatment. But even if we don't, there are other things coming, such as stem cells and some rather sophisticated electronic implants. We've been on the forefront here at Wills Eye in our research unit in having several stem cell programs for dry AMD. Now, these are stem cells that we implant surgically under the retina into the center here. You can see this is a patient with advanced dry degeneration shown here. We do a limited operation called a vitrectomy and then inject a solution of stem cells that have these pigment cells that grow under the retina and can hopefully allow for some rejuvenation or improvement in the function of the macula. We've had some favorable phase 1 experience, and we're launching phase 2 with 2 stem cell programs here at Wills. And then there are surgical implants. You might have heard the term bionic eye. There's rather sophisticated electronics that have now actually been FDA approved. This is actually for a different type of retinal condition, advanced retinitis pigmentosa, and it's shown some benefit. We were part of the clinical trials, and we've actually implanted this so-called Argus 2 device here. But more sophisticated, higher resolution devices are coming, and we think that might also help our patients with advanced AMD, dry or wet. I'd like to now shift gears to the wet form. This is where we're sort of most proud because we've had tremendous progress. It was devastating for patients to go from dry to wet. Just 15, 16 years ago, anyone like us that have been in practice for longer than that used to tell patients they'd present with wet AMD and only 1 out of 10 could be treated with laser. That's all we had, and laser was minimally effective. 9 out of 10 patients were not treatable, untreatable, and they went on to progress to legal blindness in the affected eye. At around 2000, a big development called photodynamic therapy hit the scene. That allowed us to treat a lot of wet AMD. It didn't improve the vision, it just minimized how much vision loss. But it was just the past 10, 11 years we've entered what's called the anti-VEGF era. This is truly highly effective ways to treat wet degeneration. As you can see down here, these treatments may have slowed the vision loss rates, but for the first time, very first time, we now have a treatment, again, just 11 years ago, hitting the scene, that we can improve vision. So what is anti-VEGF therapy? Well, VEGF is a growth factor. It's the main growth factor driving abnormal blood vessel growth. That's what wet degeneration is. Wet degeneration is, all of a sudden, abnormal blood vessels grow under the center of the retina, and as they grow, they leak and bleed, and then eventually scar. And that's a quick process. Usually, it's all over in a year or two. So if you catch it early, you can administer an anti-VEGF drug that stops the blood vessel from growing, stops the leaking, and usually preserves and often improves the vision. So we have molecules like antibodies or antibody-like molecules that we inject in the eye that blocks the effects of VEGF on the abnormal blood vessel to prevent it from growing. And yes, this may be a little gory, but we do injections in the eye. We do them every day because these medicines are so effective for this condition, among other common retinal conditions. We use the drugs every day in practice. And there are 3 very good anti-VEGF drugs and even better ones coming. So I mentioned earlier that we have technology, a diagnostic tool called OCT that can give us a cross-section image through the macula, and that's what you're seeing here. This is when the patient first presented. This is an OCT of the macula, and what you're seeing is the retina lifted up by blood and fluid under the retina, here and here, fluid in the macula, the retina. And after just a few injections, you can see how the retina starts to look much more normal. All the signs of blood and fluid are going away, and that can occur quickly. We can often improve people's vision with monthly injections after just 2 or 3 injections. But the challenge thereafter is keeping the macula dry and keeping this condition in check, because these drugs do not cure the condition, they only control it. So I'm only going to show a couple of technical graphs, but this one is particularly important because Lucentis, the first FDA-approved anti-VEGF drug, Eylea was the second FDA-approved anti-VEGF drug, showed in clinical trials for the first time ever, the ability to improve vision. So these curves here show visual acuity improvement in letters, 6 letters, 10 letters on average. That's a couple of lines on the eye chart of vision improvement compared to the natural history or even photodynamic therapy where the vision was declining with treatment. And the difference is 4 or 5 lines on the eye chart. It's amazing. We've never, ever had anything that could do that. And so now we're living in an era where we can, on average, improve vision when patients come down. And after the introduction of these drugs, you can see in those clinical trials, the drugs were administered monthly. Remember, you can control the condition, you can't cure it, so that meant monthly for the rest of your life. That's not an easy thing to do, even with great results. So a lot of what we've done at Wills since the introduction of these drugs is help to refine the protocols so we can optimize treatment and minimize the burden. And we've been able to show that we can control this disease very well with 2 lines of more vision improvement. This is some data we published just a couple years ago using modifications of treatment protocols where we can vastly reduce the frequency of treatment, about 7 to 8 in year 1 and about averaging 6 or every other month thereafter. So with our available drugs, we can control this condition with much less injections, much less office visits and so forth. So the past 10 years have been about refining these drugs. But as you can see, we can do better, and we do have a lot more to do to manage and more effectively control macular degeneration. So the fact of the matter is our unmet needs are still pretty obvious. We still have to treat forever. We still have to treat relatively frequently, and not everyone improves, and not everyone has great vision. So we are looking into the future now, and we're testing a lot of very promising types of new drugs and devices and so forth that will definitely provide us with the progress and the answers to those unmet needs. A couple of new anti-VEGF agents in phase 3 testing right now. Within another year or two, we're bound to have another drug or two that we hope will last longer, for example. And then Rob mentioned devices for sustained release delivery of drugs, and that's a hot area of research. There are various devices that I'll show, gene therapy even, for producing drugs that work like anti-VEGF agents. This is a phase 2 study we're working on right now. It's a neat little device that you go to the OR, you fill with a concentrated version of Lucentis, it's inserted in the eye, and then it's refilled in the office. And it gives a slow release of the Lucentis anti-VEGF drug over about 6 to 8 months. So here it is right here. You can just barely see it. And that's a diagram of how it's inserted in the eye. Very promising way to deliver anti-VEGF therapy for the long run. And even more fascinating is gene therapy. And this is just hitting our scene. Ophthalmology in general has been leaders in gene therapy. We're bound to have a gene therapy in ophthalmology for retinal degeneration within the next year or two. And usually when you hear about gene therapy, it's injecting a gene product so your body can produce a normal gene in a condition that has an abnormal gene, right? Gene replacement. Here, we're using gene therapy to make your body a pharmaceutical company, to be able to have your cells of your eye produce a drug, an anti-VEGF agent in particular here. So we are basically introducing DNA that encodes for an anti-VEGF drug, put it in a virus vector, and inject it in or under the retina. And that allows for a continuous, long-term, indefinite anti-VEGF therapy. And that's made it to some degree into phase 2 testing, but there's still some work to do for that. But very exciting technology. But all I've talked about is anti-VEGF. I haven't mentioned that there's a whole host of other targets and a plethora of drugs that target the abnormal blood vessel pathway that will potentially work in concert with anti-VEGF drugs to get better control of this disease. So everything you see listed there is in some phase of clinical testing. And our active research unit actually has tested 90% of what you see here. And so one very interesting one coming is this one in phase 2 testing. So the pharmaceutical companies have been really major players in providing some of these great new products. Genentech, for example, is developing an antibody that binds 2 targets. Right now, an antibody binds VEGF, for example, one target. But now they developed an antibody, as shown here, with 2 arms. One binds VEGF, another one binds another growth factor called angiopoietin. So with one injection of one drug, you might be able to have true combination therapy. We think the future for wet AMD is going to be like what oncologists do in cancer treatment, using a combination of drugs that work by different mechanisms of action to allow for better control of what is uncontrolled blood vessel growth. That's what wet AMD is. Our research unit, since I started it now 18 years ago, have performed over 100 major clinical trials. This is a list of dry and wet AMD that are active right now. As you can see, we're involved anywhere from phase 1 to phase 3 in virtually everything in development. So we're proud to say we've been a part of the field growing forward and going forward in terms of the next great developments. So this has been an exciting research space, and to be a retina specialist and a clinician taking care of patients with macular problems, it's been a whole new great world. I mean, now I can tell patients we've got a great treatment for wet AMD. If we catch wet AMD early, we can really get good results. But we can do better. We are going to do better because there's some very promising new drugs and technologies out there for both dry and wet AMD. I'm happy to entertain any questions, and for those of us out there, including myself, that will probably have AMD at some point, I hope to make a lot more progress in this space.